Approach, Early Childhood Mental Health Prevention and Dyadic Care in Pediatric Primary Care. And I am thrilled to be joined today by Dr. Rahil Briggs. My name is Evelyn Blank, and I'm the Executive Director of New York Center for Child Development and also the Director of the New York City Early Childhood Mental Health Training and Technical Assistance Center. Before we get started, I just wanted to go over a few logistics about today's webinar. And as we've always done in the past, the webinar is being recorded and will be posted along with the slides to the TTAC website, and we'll give you that link in a few minutes. We will also be taking questions throughout the webinar, and we ask that you chat in your questions using the chat functionality, selecting all panelists on the drop-down. And we will have time at the end to really respond to all and address these questions. For those LMSWs and LMHCs interested in obtaining CEUs, you will be eligible to receive 1.5 CEUs for attending this webinar. If you are only joining by the phone, we would need you to log into the WebEx via a computer in order to obtain credit for the CEUs. And further info and instructions will be distributed via email following the webinar. Finally, towards the end of the webinar, we will be sending out the feedback survey using the chat functionality. And we really ask that you fill it out, click on the link, and really fill in your responses. This is very important to us to get your feedback in terms of future offerings and planning. So just quickly who we are, the New York City Early Childhood Training and Technical Assistance Center, otherwise known as TTAC, is funded through Thrive New York City in partnership with the New York City Department of Health and Mental Hygiene. And TTAC is a partnership between the New York Center for Child Development and the New York Silver Institute on Poverty Policy and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, and we have expertise in both informing policy, but also promoting the field of early childhood mental health, both through training as well as direct practice. And we're thrilled to be partnering with NYU McSilver Institute for Poverty, Policy, and Research, which houses the Community and the Managed Care Technical Assistance Centers, otherwise known as CTAC and MTAC, which offer clinic, business, and system transformation support statewide to all behavioral health providers. And just to say that TTAC is charged with building the capacity and competencies of mental health and early childhood professionals through both ongoing training and technical assistance. And Kevin, if you could just move it to our website to let people know where they can access resources, where we'll have upcoming events, archived webinars, and other resources that are available. So it is now my pleasure to introduce Dr. Rahil Briggs, who has been a long-term colleague and a true pioneer in integrating healthy steps in primary care. And I want to say that I've been the beneficiary of her generous technical assistance in terms of really talking about how to integrate behavioral health into primary care. She is the National Director of Healthy Steps, the program of 0 to 3. And since joining 0 to 3, she has overseen the dramatic growth of Healthy Steps to more than 165 sites across the country, reaching approximately 250,000 children and families in 2019. And she oversees every aspect of the program, from the financial to the operations to professional development and training. She comes to this role after a successful career at Montefiore Health System in New York, where she grew the Healthy Steps footprint from more than 21 practices, serving over 30,000 children annually. Additionally, Dr. Briggs is a founder and former director of Pediatric Behavioral Health Services at Montefiore Medical Group, one of the largest integrated pediatric behavioral health services in the nation. She is the editor of Integrated Early Childhood Behavioral Health and Primary Care, a guide to implementation and evaluation, and she is also a clinical professor of pediatrics, psychiatry, and behavioral sciences at Albert Einstein College of Medicine. So thank you, Dr. Briggs, for joining us today, and we look forward to a really interesting webinar. Thank you.
Thank you so much, Evelyn, and thank you to the really impressive collaboration that you all have put together here between TTAC and the New York Center for Child Development and McSilver at NYU. I'm honored to be here and chat with everybody this morning. Those were a lot of numbers you just threw out. I think the most important number for us all here is 0 to 3, and the importance of getting it right in those early years, and how we can partner with pediatrics, with pediatricians. I'm a child psychologist by training. I just pretend to know some things about pediatricians, and if really my own career, and I hope the lives of many children and families, have been changed by the partnership between early childhood mental health and primary care pediatrics. I think today we're actually at 170 sites across 23 states, Puerto Rico and Washington, D.C. And New York, my home and your home, is actually our biggest footprint with 47 sites, upstate, downstate, Long Island, and the like. So I hope to chat with you guys for the majority of our time today, but really leave a significant amount of time for questions. So get your questions ready, and I look forward to our conversation. Oh, sorry, this is the slide that I think Evelyn was hoping that we would show earlier as she was talking about TTAC and the partnership with DOHMH and the New York Center for Child Development and so on and so forth. So I'll look this up for just a second so people can see that website at the bottom, ttacny.org. And there's a wonderful screenshot of the website. So our agenda for today, just to really give you an introduction about what HealthySteps is and some of the evaluation and evidence that we have accumulated over a 2-decade-plus history with RCTs and local evaluations. Then talk about some return on investment. Evelyn, I don't know if you could mute yourself, actually. I'm getting a little bit of background noise, and I'm not sure if other people are as well. Just talk about a little bit, thank you, about return on investment. That's not something we often talk about in early childhood because we say, oh, well, kids are cheap and they don't cost us a lot of money. But there's a real opportunity here when you think about the dyad. And then really how to get started and talk a little bit about how I got started in my journey. And then, like I said, leave a good amount of time for questions and answers. I hope today that we will focus primarily on why partner with pediatricians. Who are they, what do they do, and why is it so important that people in our field, in the mental health field, and especially the early childhood mental health field, partner with those pediatricians, and how do you get started? To also describe how we have created an evidence-based model with fidelity metrics and core components, and really how that then leads to the evidence-based and return on investment. So as I said, what's HealthySteps? Evidence-based, interdisciplinary program. The basic idea behind HealthySteps is you add a new team member to the pediatric primary care team, and that person is a HealthySteps specialist. They are most often a master's level social worker, and I know that applies to lots of you on this webinar today. The second most common category is a doctoral level child psychologist. And the third most common category is other master's degrees, so LMFTs, early childhood educators, and the like. That HealthySteps specialist partners with the pediatric team, not just the pediatrician, but the nurses and the front desk and everyone within that team to ensure that we provide a continuum of services to make sure that infants and toddlers leave that pediatric practice ready for school, ready for life, and ready for success. So why pediatricians, right? As I said to you before, I'm a child psychologist, and I started my career working in an early childhood mental health clinic that I'm sure a lot of you have done as well. I was up in the Bronx at the Early Childhood Center at Albert Einstein College of Medicine. We saw children from birth to 5, and so you'd say, wow, so preventive. How early, how wonderful. And I'd say to you, yes, except if you are the parent of a toddler, or you have ever been a parent of a toddler, or you know anyone who's a parent of a toddler now or previously, imagine what it takes to bring that toddler, much less that infant, to a child psychology clinic or an early childhood mental health clinic. Things have to have gotten really, really bad. We're no longer looking for prevention and early warning signs, and it's actually not that preventive because there has to be such a significant identified problem for most families to really cross that threshold and go to an early childhood mental health clinic. Now, on the other side, there's pediatrics. And pediatrics is this unicorn of a place where you go and you take your child even when there's not a problem. Especially in those first 3 years of life, there are 12 to 13 child visits. That's a phrase that gets thrown around a lot, but unpack that. Well child. These are not kids with a diagnosis. These are not kids with a problem. These are not even kids with a concern. It's our country's approach to primary prevention for young children. And it's wonderful because you check if they're growing right and if they can see and hear and give them those needed vaccinations. But what HealthySteps does is also make sure that you get that needed approach that includes development, behavioral health, and parent-child relationships within primary prevention. Again, not waiting for a problem to emerge, but really going in at that primary prevention level. In the next slide, I'll talk a little bit about our 3 tiers. But let's stay on this for a minute. Access. So we all know that we have significant problems in terms of healthcare and equity. We know that we have a very significant maternal mortality problem in this country, and that cuts along very serious racial and ethnic lines. We know that children of color are more likely to live in poverty. They're less likely to be screened for autism. They're less likely to be effectively connected to early intervention. Young mothers of color are less likely to be screened for maternal depression and are less likely to be connected with maternal depression services. But within primary care pediatrics, you don't see that same racial and ethnic disparity. Almost no matter your background, children are coming to pediatrics. There's a slight difference between Medicaid and non-Medicaid. There's a slight difference between racial and ethnic groups. But even in the group with the lowest rates of going to pediatrics, they're going to over 85%. Over 85% of those children are going to the pediatrician. Over 85%. And that's the lowest. In the highest groups, it's over 95%. We don't have anything else like that in this country. Not every child and family goes to early learning, early childhood education, Baby and Me, Montessori, faith-based organizations, right? But this is this extraordinary access. Second, trust. I don't know about the experience that you've had as an early childhood mental health provider, but the experience that I've had as an early childhood mental health provider is one of a lot of mistrust or distrust. People worry that you're going to be too quick to diagnose their young child. People worry that other people are going to know that that young child has a mental health diagnosis. They're worried to even be known that they went into your clinic, that they stepped across that threshold. Again, it's the complete opposite with pediatrics. Almost no matter your background, you're a good parent or a good caregiver if you take your child to the pediatrician. And in study after study and survey after survey, after people's immediate families, pediatricians are at the top of the list in terms of who they trust to give them guidance about behavior and development for their young children. Pediatricians, on the other hand, have 15 minutes in which they're supposed to do a well-child visit. And in those 15 minutes, they're supposed to do everything from vaccinations to making sure the kid's growing to, fluoride in the water and bicycle helmets and the like. And then we say, yes, and also please focus on toxic stress, adverse childhood experiences, social determinants of health, parental mental health, the attachment relationship, and the child's social emotional development within that last minute. Not going to happen. So HealthySteps very much borrows in the trust instilled in the pediatrician to bring that early childhood mental health prevention into this universally or almost universally accessed setting that is so deeply trusted. This slide says that the setting is also non-stigmatized. And I know it's not a real word, but I like to say that it's actually positively stigmatized, right? Again, you're a good parent or a good caregiver when you bring your child to the pediatrician. And then I already mentioned that frequency. I know as mental health professionals, often when you're in a mental health clinic, you get a referral and you do the requisite outreach to try to get that family in for the initial intake. Or if they've come in for that initial intake, you do some more outreach to try to get them back. And you probably have a system so that you don't exhaust yourself of maybe outreaching twice via phone and sending a letter or something. And then just because of the reality, you have to close that case. And you wonder and you worry about what happened to that family, and you hope they got connected. And that's very different than what happens in pediatrics. They have 12 to 13 visits in those first 3 years of life, 7 of which are in the first year of life. So if you miss them at the 1-month visit, guess what? They come back at the 2-month visit. And if you miss them then, they come back at 4 months, 6 months, 9 months, 12 months, right? So you have these repeated opportunities to engage with families when they're ready to really focus on this sort of work. So I promised you a slide, a little bit busy, but stick with me, about how we approach being both population-based and risk-stratified. This is important. You're all in New York City for the most part, in New York State, and you know how many darn kids we have to focus on. I went to NYU for grad school, and it was in the 90s, and it was when welfare reform was happening under the Clinton administration, and I almost dropped out of grad school. And I thought I should go to law school. Like this, being a child psychologist, I'm going to help one family at a time. There are too many families that need help and that could benefit from help. Maybe I should go to law school and change the laws. Who knows, that probably might have still been an approach, but I had a very good advisor at the time, Dr. Gil Trackman, who said to me, I don't know, Rahil, is that really what you want to do, and is that really going to feed you? And I said, no, but I've got to figure out a way to move beyond one kid and one family at a time because there are just too many. So thus, a population-based model that also has the ability to be risk-stratified. Population-based means that our Tier 1 universal services are delivered to every single child and family within a HealthySteps practice. Not based on what kind of insurance they have, not based on their risk factors, but if you're within that birth to 3 age range, and some of our sites go up to 5 and some even start prenatally, but we require birth to 3, you're going to get these 3 core components. Universal screening for child concerns, which includes autism, social emotional development, and regular development. Universal screening for family concerns, which includes maternal depression and social determinants of health and other risk factors. Almost all of our New York sites also screen for adverse childhood experiences. And then follow up on those screens because screenings without follow-up are not very helpful to anybody. Moving a little bit up in that risk-stratified model, you see Tier 2. And Tier 2 are for those children and families that have just the earliest possible warning signs that something's not perfect. And I like to call those light pink risk flags. Not red flags, not like alert, alert, there's a crisis, but light pink risk flags. And for those families, in addition to everything they got within Tier 1, they also receive our next 4 core components. First is child development and behavioral consults. So what does that mean? It means that you come in for your, 18-month checkup, and baby's not sleeping well, and it's starting to really take a toll on the family, and the pediatrician talks to them about it for a couple of minutes, then says, you know what, let me see if HealthySteps is available to come talk to you because I've got a waiting room full of patients, and I really want to spend some time on this. Call in the HealthySteps specialist with that very important warm handoff. Oh, let me see if Dr. Briggs is down the hall. She knows about this stuff better than I do. I remember once my mentor at Montefiore, Dr. Racine, saying exactly that. And think about that, this wonderful, august, knowledgeable pediatrician saying to his patient, you know what, let me see if Dr. Briggs is here. She knows about this much better than I do. Versus what we do in sort of standard care where we say, oh, gosh, that sounds like a problem. Here's some guidance, delivered usually not in a motivational, interviewing, or effective way. Like, here's some things you should do, parent. And then here's a phone number for a clinic that's not even in your neighborhood and may not be open when you need it to be open, and you don't know them from Adam, but here's their phone number and call them, versus, the way he said it. Care coordination and systems navigation is core component number 5. Say that a bunch of times. Care coordination core component. And what that means is that the Healthy Steps specialist and sometimes the community health worker that works alongside the Healthy Steps team spends a huge amount of time making sure that every single referral that comes out of the pediatric practice sticks. We know that you can't solve all the problems that families are facing within those 4 walls of the pediatric practice. And so those referrals that go out into those community-based organizations and some of the services that you all represent today, they stick better when there's someone making sure they stick and understanding what is the family's concerns and worries. And maybe it's a cultural mismatch, or maybe the way that it's just been described, or maybe the phone number's not right, or what have you. So big focus on care coordination and systems navigation, and I'll share with you some evidence around that core component in a bit. Core components 6 and 7 are a focus on positive parenting guidance and early learning resources, including literacy and STEM. Healthy Steps is a program of 0 to 3. 0 to 3 is our nation's largest operation focused solely on infants and toddlers, and really has a wealth of resources around positive parenting guidance and all those early learning resources. So we leverage that from our parent organization 0 to 3 and make sure that families have that access as well. And then finally, Tier 3. Tier 3 families are those families that we are most worried about. But remember, this is not hopefully because they already qualify for a whole slew of diagnoses, but because we're seeing risk factors that we know set families up for less than a perfect early childhood. Maybe it's things like a parent who's struggling with a mental illness, or a family who's living in public housing, or a child who had congenital birth challenges and is born and spent time in the NICU or is very low birth weight. We do not tell our sites what their risk factors need to be. In 170 different communities across the country, far be it from me to let them know what they're looking at in terms of risk. We have sites in Alabama and Arizona. We have sites in New York and California, and risk is going to look very different. But for those families designated as most at risk for Tier 3 services, they receive everything in Tiers 1 and 2, plus the Healthy Steps specialist co-manages each and every one of those 12 to 13 well child visits alongside the pediatrician. And they focus on that parent-child relationship, on the child social emotional development, the parental mental health, and the attachment relationship. So I know I spent a lot of time on these last 2 slides, and we'll move through the rest of it a bit more quickly, but this was really, really important to describe the extraordinary platform that is pediatrics, the challenge of doing everything within a 15-minute visit, and then the solution of creating a risk-stratified model so that families get what they need and how much of it in a place that they already are. So these are those 8 core components just listed out differently. It's the same stuff you saw on the previous slide, just not in that tier. Healthy Steps practices must do these 8 core components. They can do more than this if they want, right? Some of our sites in Arizona, for example, they are all certified lactation consultants in addition, and so they add that on. Some of the sites in New York City also add on parental mental health. But these are the things you really have to do if you want to call yourself Healthy Steps. So let's jump into real quick some of the evidence. As I mentioned, Healthy Steps has been around for over 20 years. I guess now over 30 years. And there's a real history of evidence building. Initially, there was a randomized control trial that was national, sites across multiple states. Also had an additional arm of the study with a quasi-experimental comparison study, all sorts of work that was published in JAMA and Pediatrics, as you do. And then in like 2004, 2005, after all that stuff had been published, there was a decade that sometimes I call sort of the Wild West decade of Healthy Steps, where there was a limited national infrastructure and there wasn't a whole lot of guidance around exactly how to do Healthy Steps. And so there was a lot of variety, we'll call it, within the network. In 2015, HealthySteps became a program of 0 to 3, and there has since then been a very significant effort to bring some fidelity to the network so that a HealthySteps program in Arizona doesn't look so different than a HealthySteps program in Alabama. This slide is already a bit outdated. It's from 2019, and currently, as I said, we're at 170 sites. We, of course, took a pause during COVID in terms of onboarding, and although we were still very much within COVID, we have switched to virtual onboarding and started to once again bring sites and networks back into the system. So let's walk through some of the evidence then that we are seeing. We've divided it up into these 8 areas. You can find this on our website, which is healthysteps.org, at the evidence. And I'll just briefly walk through some of these areas and give you a few highlights to just really express sort of what we're talking about here. So connections to resources. The bottom line is when you just put a referral out there into the black box of referrals, it doesn't usually go very well. And so HealthySteps works very hard to make sure that families actually get connected to the resources that they need. Breastfeeding and early nutrition. As I said, those HealthySteps specialists in Arizona are all certified lactation consultants. But even when that's not the case, there's such an extraordinary ability in that newborn visit, and then often families come back for a 1-week checkup or a 2-week weight check. And there's a wonderful opportunity to really sit with families and understand how things are going in terms of breastfeeding. And then nutrition. You say, well, wait, you didn't talk about this as a nutrition program or an obesity prevention program, but you'll see some evidence on this slide that there is evidence that we are preventing obesity in young children, because when you think about early childhood obesity, if it's not a congenital issue, it's often a parent-child relationship is playing some role in that. You know, the baby is not making themselves the lasagna. And families sometimes use food as a behavioral tool in ways that doesn't end up to really work out so well. So just some data there on the breastfeeding and early nutrition. Child health and development is really sort of the bread and butter of pediatrics and the bread and butter of HealthySteps. And we look at this both in terms of things like parent-child attachment and up-to-date vaccinations. We have significant data from the RCT and subsequent site-level studies that show that children are more likely to attend their well-child visits, they're more likely to be up-to-date on their well-child visits, and they're more likely to get those really needed vaccines. We have some evidence that even during COVID, some of our sites have really gone above and beyond to make sure, using pediatricians, nurses, and HealthySteps specialists to make sure families feel comfortable coming back in and getting those vaccinations. One of our sites in North Carolina made over 200 calls to HealthySteps Tier 3 families in the first weeks of COVID and made sure that each and every one of them came in for that child's well visit when needed. Parenting knowledge and practice, we know that if this was as easy as sort of giving people a one-pager on, you know, don't hit your kid, and here's how to do time out, and here's how to do time in, then we'd be living in a different world. But we know this is so much more complicated than that. Culture, family of origin, the ways in which we were parented drive so much of our behavior and our knowledge in this area. And so it becomes critically important to have that true relationship-based intervention where you trust that HealthySteps specialist who is there for you through all those newborn visits before the kid got too difficult, right? And then as soon as you start hearing no, no, no at 18 months, and as soon as you started seeing those tantrums at 21 months, that HealthySteps specialist had created that trusting relationship with you where you could really unpack some of these issues. Parent and physician satisfaction doesn't often get a lot of attention because it's like, oh yeah, right, people like the program. But let me just sit on this for a minute. Burnout is a real challenge with our medical providers. COVID has been, people have described it to me, pediatricians have described it to me as being in New York City and feeling like they were in a war-like environment. And so when we can add a new member to their team and we can really do good, high-quality, team-based care, we can move the needle on their own job satisfaction, their own burnout, their own turnover. Parents often say that this is what they've been looking for all along. There was a wonderful article in USA Today yesterday that highlighted HealthySteps and nurse-family partnership, and it talked about a mom from HealthySteps in the Bronx at Montefiore, and I'm going to misquote it, I'm not getting it right, but she said something like, I've been looking and looking for what healthcare should be, and I found it, it's HealthySteps. So parents really say, this is what I wanted all along. You see that from the research. There's been wonderful focus groups from Tumani Coker and others that show that parents say what they want from pediatrics is everything they're getting and a real focus on behavior and development, please. And so really moving the needle on both physician and parent satisfaction. I already talked a little bit about maternal depression. We require maternal depression screening, so if you're going to be HealthySteps and do it at Fidelity, you must screen for maternal depression. So that's really, really critical. And we see there that screening then leads to connection with resources. You remember I said that early literacy and school readiness, that's one of those core components, right? Early learning resources, including literacy and STEM. The vast majority, over 3/4 of our HealthySteps practices are also reach out and read practices. And even if they're not reach out and read, giving out the book and really creating an early literacy environment, they have to focus on literacy in some other way. School readiness, I mean, talk to any good kindergarten teacher and she says, you know what, it's not necessarily the kid who could, do the ABCs backwards who I knew was really going to make it. It was often the kid who could sit in circle time and share with the kid next to her. That's the kid I really felt good about. And so we think about school readiness as beyond numeracy and literacy, inclusive of and beyond, really thinking about the social, emotional development of children as well. And finally, child safety. Something that we are thinking a lot about during this time of COVID, and something we think about even when things aren't quite so dire, but really making sure that children are physically safe and less likely to go to the emergency room, less likely to sleep in unsafe ways, and the like. So that's a lot of evidence I just threw at you, and I'm going to share a little bit more now. Everything I just shared was from the randomized control trial and some other published literature. Now I'd like to show some hot off the presses. This has either been presented at a professional meeting or is in press evidence. This is from our work in Washington, D.C. We have a phenomenal HealthySteps site there through Children's National. They have 2 sites. And they looked here at their ability, and their patient population, I should tell you, in those Washington, D.C. Children's National sites is almost 95, 98% African-American Black. And so they looked at, before they had HealthySteps, how successfully were they connecting families to early intervention, Part C, speech therapy, OT, PT, you guys know it well. And then after HealthySteps, how did that change? Because they really wanted to focus on this and make sure those referrals stuck. And also we asked them for that for data every year in their data reporting. And you'll see here that even for the littlest ones, those 9 and 10-month-olds, and if any of you have ever tried to refer a 9 or 10-month-old to early intervention, you know it's tough to get them to qualify because you have to be a certain amount delayed, et cetera. But they doubled their successful referral rate for those little babies. And then for children who are, 18 to 19 months, which is still quite young, getting a little old for me, but I know for most people it's still really young, they quadrupled their successful EI referral rates. Moving from DC just over to Maryland, this is from a family medicine site in Baltimore City. And they're doing some really excellent work because they're family medicine. They're enrolling families prenatally. And they've done some great work looking at how the trimester of enrollment, first, second, or third, has some impact on maternal depression in the way that you'd imagine it is. But they also did a focus group with their primary care providers, that's what PCP stands for, and asked them sort of what they thought about it. So it was with both residents and physicians. And you'll see here some quotes. I can't say there's ever a day in clinic when I'm not looking for my HealthySteps specialist. I ran into a resident once at Montefiore who said to me, Dr. Briggs, my site doesn't have HealthySteps, and I feel like I've got a kid with a heart issue and I don't have a cardiac unit with an EKG. How am I supposed to practice medicine? And so really, once you expand this idea that the practice of pediatrics and family medicine and the like is about more than just physical wellness, but really encompasses development, mental health, and parent-child relationships, it's hard to imagine doing it any other way. From Maryland, we move to New York. This is some wonderful data that I referenced before about the ability to successfully refer out from the pediatric practice into the community. And so what you see here is over a 6-month period at Montefiore, 192 HealthySteps Tier 3 patients. I think this was across 2 or 3 practices. I don't totally remember. And almost 45% of those kids got a referral outside, kids and families, right? So this is not just every once in a while. This is almost half of the families got a referral out. And so you see the categories. This is not just about Part C early intervention, but also housing, which if you're in New York City, you know is really difficult to solve for. Domestic violence that is difficult to solve for wherever you are. And what you see here is that the vast majority of those referrals worked, right? And worked is defined as the kid and the family actually got linked to that service. And they got evaluated for the service. And they're either getting it or they were evaluated and didn't qualify. Compare this to national data that suggests that maybe 20% of referrals actually stick, and you're seeing a really significant difference here. And finally, sticking in New York City at Montefiore, we're looking at lifetime emergency department visits. So we enrolled, back when I was at Montefiore, an initial treatment and a control sample. And these kids are now like 10 and above when this data was pulled. And we see a very significant difference in lifetime emergency department visits for these kids who are now 10 and 11 years old, really showing that some of these interventions stick long after the HealthySteps services have stopped. So thanks for sticking with me. We're going to get in now to what is not always something we talk about in the early childhood field, but this idea of return on investment, or ROI. So hopefully you all have seen this picture often. This comes from the Nobel Prize winning economist James Heckman. Evelyn and I have done many, many presentations together, and I think we always fit this in there. We lean on the shoulders of this wonderful work often. And what this shows is that it's more expensive and more resource intensive to intervene later versus earlier. That's just the basic way to say it. If you want to really get sort of crass and just transactional about it, you get more bang for your buck the earlier you intervene, right? And these data, it's fascinating to look. If you go to heckmanequation.org, I think you'll see what all of these data suggest, and you also see over on the right-hand side of this slide, you know, it's not just early wins like improved cognitive and social emotional development, but he and his team have now tracked families for decades and see that these families who received that high-quality early intervention are more likely to be successful in the job market, so they're giving more tax dollars back. They're less likely to be involved in the juvenile justice and criminal system, and that actually is the biggest difference in the return on investment, is the decreased involvement in juvenile justice and criminal justice systems. Again, those early years set the foundation for wellness. It's much like the foundation of a house. We're all spending a lot of time in our houses these days. And you know that if that foundation of the house is strong and well built, the house can withstand storms. If the foundation is not well built, then the slightest windstorm topples a room. It is the same for young children, that those early years are absolutely foundational. Jack Shonkoff very famously says that age 3 is middle age when it comes to brain development. Try that on. And so getting it right in these early years has these long-standing results in things like criminal justice. Why? Because setting that foundation and getting that foundation right early on is so critically important. I love talking to people who found their way to the early childhood field, and I think so often they say things like, well, I was working with middle schoolers, talking to someone yesterday who said that he was in Teach for America working with middle school children and thought, oof, this is too late. I need to go meet with these kids when they're earlier. So the way we think about return on investment and cost effectiveness in HealthySteps is, as you can see on this slide, but I'll walk through it for you. So basically, one full-time HealthySteps specialist can cover a pediatric practice with up to about 2,000 children and families, right? And so how can they do that? Well, they can't see all 2,000 children and families. Remember that I said we partner with the whole practice, the front desk, the nurses, the pediatricians, and they're really doing a lot of those tier 1 services in terms of getting the screening in the family's hands, getting it scored, and getting it put into the electronic medical record. Getting the pediatrician trained up so that they can really have that first stage conversation with families, and then only bringing the HealthySteps specialist in when needed on tier 2 and tier 3 kids. And because these are often short-term interventions in tier 2, and then in tier 3 they follow the well-child visit schedule, you can have around 250 children and families in each of those tiers in a year with your one HealthySteps specialist. And so the cost that you see here is pretty extraordinary in terms of how low it is. When that HealthySteps specialist is really operating at top speed, if you will, and optimal capacity, that cost looks like $200, as low as $200 per tier 3 child per year. 200 whole American dollars for the whole year of these tier 3 services that get you all of those outcomes that we just went through. Compare that to the costs of fixing things later. Compare it even to the costs of home visiting. Home visiting is critically important, hear me clearly, and we rely very heavily on our partnerships with our home visiting colleagues, but I'm not sure that home visiting needs to be universal. I'm not sure that everybody needs a home visit. And I know from having been a home visitor myself in early Head Start, not everybody wants a home visit. And it's really, really expensive and resource intensive, right? So in a really good continuum of care for our young families, you see HealthySteps as an exceedingly cost-effective intervention. And so our return on investment averages around 204%. Invest $1, get, a couple dollars back. We have done this work over multiple states and multiple sites with Manat Health, not just internally, and we focus on these 8 cost savings interventions. You'll see that 3 of them are on the child side, and 5 of them are actually on the adult side. So I referenced that early on, that I really want to make sure we talk about the dyadic nature of programming in primary care. Different than early childhood education, where children come maybe dropped off by their parent, but then mostly the parent does not stay. Parents are really there for every second of that well-child visit. I mean, think about it. You're not intervening with the kid on how to sleep train themselves at 6 months. This is all intervention with the parent, right? And if you're looking for parents, I have a secret for you. They're at the pediatrician's office. Nobody has to, we're not doing a poll. You don't have to tell us when you last went to your well check as an adult. But parents are much more likely to take their child to the pediatrician than they are to take their own selves to get their well checks. We focus on that, not to worry, but that is the fact of the matter. So if you're looking for parents, you're going to find them 12 or 13 times in the pediatrician's office in those first 3 years of life. So really the ability to do this wonderful dyadic 2-gen work And I think these interventions speak for themselves. On oral health, it's just the idea that HealthySteps specialists make sure that one of those referrals outside is to the dentist and that it actually sticks. Inappropriate use of care for ambulatory sensitive conditions is kind of a lot of big words that may not mean anything to you, but it's basically the idea that you don't go to the emergency room if you don't have to, right? How the family calls into the practice, HealthySteps is able to say, oh, I'm sorry you can't connect with Dr. So-and-so right now, but let me see if a nurse is available and chat with you about those symptoms and whether or not you can just come in for a sick visit later this afternoon instead of going to the emergency room. On the adult-focused interventions, you see things like breastfeeding, which we already talked about, maternal depression, which we spoke about. Intimate partner violence is one of the required areas of screening for our annual social determinants of health screen. Unhealthy birth spacing. So we know from a lot of the evidence that there is such a thing as an unhealthy short amount of time between births in terms of the toll it takes on a mother's body and the outcome of children. And so HealthySteps specialists are often able to really make sure that mama can attend that 6-week postpartum checkup, which doesn't have a great metric in terms of attendance for moms. HealthySteps can really make sure that mom's able to attend that and think about her own family planning decisions with her partner, with her family, and how she wants to proceed. And then smoking cessation, again, is one of our areas of screening on the social determinants of health. So basically how you would get started in this, our HealthySteps practices are affiliates. We don't own them. We don't hire the HealthySteps specialists here at the national office. Usually the practice hires the HealthySteps specialist, and they sign some affiliate agreements, and they're part of our affiliate network. So you see here a nice little infographic of how this goes. But basically the idea is that a practice decides they want to do HealthySteps, and they get the funding to do it, and they hire their HealthySteps specialist, and then we start making sure that they have the requisite administrative buy-in. Little secret, if you want to change something in pediatrics, get the pediatricians to work with you, because docs listen to docs, and again, we really borrow in the trust instilled in the pediatrician to do this work. There's lots of pre-planning about readiness, basically. If you're already doing 2 of those core components, we're not pretending we invented them, right? Then we don't have to focus on those in your training. This still says on-site training, which is a little bit out of date. Of course, with COVID, we have moved all of our training to virtual. And instead of doing it 2 days on-site, it's really chunked up into like 2-3-hour chunks over Zoom with the right people in the Zoom rooms. And it's both asynchronous, so there's some stuff folks do on their own, and synchronous. And so we're always trying to build that out better. And then finally, we know that if you just learn one thing, for one day, you might forget it. And so there's some follow-up technical assistance. And so it can focus on sustainability, billing, ACEs screening, so on and so forth. And we have developed a pretty comprehensive fidelity self-assessment. So each of those 8 core components have fidelity metrics tied to them, like you got to screen 90% of your kids for development each year, and how are they doing on that, and where can we help them do even better. I want to close, first take a breath and have a drink of tea, if you don't mind. But I want to close in telling you a story about a family that I met 12 years ago in New York. And this was a family, it was a mother and her young son, and he was 4. And they had been referred to the early childhood mental health clinic where I was working part-time and also part-time in the pediatric practice. They'd been referred to the early childhood mental health clinic a lot. They'd been known to child welfare, and they had never been able to make it to the early childhood mental health clinic, And so I'd done those 2 calls and a letter, and I'd outreached, and I just had never been able to get them in. But she came to the pediatric practice then on a day that I happened to be there for his 4-year checkup. And she did so because things had gotten particularly bad. And she felt like she needed help, she didn't know where to go, And she also wanted to make sure that she didn't lose his Medicaid and didn't lose their WIC, and so went to the pediatrician's office. The front desk called me and said, there's a family in the waiting room. Evelyn, I think you went off mute for a second, and we're hearing that same background noise. Just thank you. So they called and said, there's a family in the waiting room, and mom is bleeding from her face. And she tells us that her 4-year-old was scratching her on their way here. And I go out into the waiting room, and it's the family that had been referred to me so many times to that early childhood mental health clinic and had never showed up. And I started working with them, and I worked with them for about a year. They had been exposed to the most severe domestic violence that I've ever heard of. And as you can imagine, we're both suffering from very significant PTSD. And so our work together was about helping the family helping mom to gain the strength to effectively parent this child, helping the child to gain some understanding into his own emotions and the trauma that he had been exposed to, getting them safe housing and so on and so forth. What I always think about is if I would have seen that family when he was 4 months old instead of 4 years old, and could have potentially prevented what was 4 years of exposure to very significant trauma. All is not lost, however, and I will share with you, with her permission, a letter that she sent to me. The patient that I treated, he is now 16, and mom has remarried and is in a healthy relationship, and they just had a new baby girl. And so I've changed the names here, but mom has given me permission to share this with you with names changed. And this was just 2 months ago. So she said, "Good afternoon, Dr. Briggs. I hope all is well and you are in the best of spirits. David," I'm calling him David as the patient, my patient, now 16. I met him when he was 4. "David and I wanted to share some news with you about our family. We recently welcomed another member, and she's an absolute blessing. When deciding on names, David asked if he could help. And so we gave him a few guidelines because we wanted a name that embodied kindness, hope, and love, a strong name, something that would inspire. He asked us if it could be after someone, which worried us a bit, ha. He immediately assured us it wasn't after one of his 16-year-old friends, but after someone who embodied all of these things and has been there for us during various stages of our journey. You." That doctor, Mom, I can't remember her name. Rahil's a funny name, but you know it. The one that I used to see, and she helped us get the apartment and your job. And here's my favorite part. And was always trying to help me get my emotions better. My husband and I immediately agreed it would be the perfect name and also gesture of gratitude. And we can only hope in time the person behind the name inspires her to embrace and live the greatness we know she is destined for. And I'd like to present to you first name Rahil, last name, born August 11th, 2020. We hope you are well, and thank you for all you've done for us and continue to do for so many families in the community. We send love and enormous gratitude. And I share this as my journey to say that all is not lost when we have to wait until age 4 to work with families. And there can be improvements and changes in trajectories. The first thing I did when this baby was born is send her a box of books and tell Mom that even though I wasn't in practice anymore and have this job where I just don't get to connect with families as much anymore, that if anything ever wasn't perfect, I wanted to know about it immediately because we were going to do for this baby what we couldn't do for David and prevent these things from happening in the first place. So I share that with you simply to encourage all of you to think about prevention, and to think about the ability to partner with pediatrics. I think we take for granted what an extraordinary platform this is. Even during COVID, the American Academy of Pediatrics came out very strong, very early, and said that pediatricians needed to stay open and provide in-person well-child visits for children and families, especially in the birth to 2 age range. Our own HealthySteps specialists have fallen into basically, I'd say, 3 buckets of responding to COVID. Some of them have stayed in clinic, and so they are still in clinic doing what they were doing before and taking care of a lot more significant basic resource needs. Families who were never poor before are coming in hungry, and families need much more help and guidance as so many of the community-based resources have shut down or seen their funding cut. Another group of HealthySteps specialists have been doing telehealth, but from somewhere else in the practice. So for social distancing reasons and so on, maybe they're in another floor and they're sort of teleporting in via iPad to be in the well-child visit. And then another group have been simply calling families on the old-fashioned telephone and helping them make sure that they get into the practice for vaccinations and connect with resources. We know that there's been a real decrease in visits to pediatricians and a real decrease in vaccinations nationally. We also know that HealthySteps practices seem to be doing better on those metrics. And we know that now more than ever, we need to rethink our healthcare system so that we can be advocates and attend to that critical importance of the parent-child relationship within this universally almost accessed, positively stigmatized, trusted, frequently accessed system. So from last month, because this month isn't over yet, this is our map of where we are. New York is actually our biggest footprint in the country. We have 47 sites in New York, as I mentioned before. Also very big footprints in Colorado, Arizona, and California out in the West. On the East Coast, some more big footprints are in North Carolina and in Florida. You can find all of our sites on HealthySteps.org. We're redoing our website, so it's going to be even better. But for now, if you scroll all the way to the bottom, our sites, you can put in a zip code and see where the HealthySteps practice is nearest you. HealthySteps practices do not treat families who don't get primary care at that practice. So I just want to make that clear. It's not like you can still see your doctor over here, but go to HealthySteps over here to get the HealthySteps treatment. We really are practicing integrated care. So the families need to either switch to a doctor in that practice or be in that practice. And our plan, right now we're serving about 280,000 children and families every year, this year. Our plan, however, is to serve over 1 million children and families per year by 2032. Because remember, it's going to take one at a time, but we've really got to do this on a population-based level. So by some miracle, we are exactly at 11:30 by my count, and I think we have plenty of time for questions and answers. I asked questions definitely and hopefully answers. I asked Evelyn if she could help me moderate the chat box so that we could make sure that we get to all of your questions and really take advantage of this half hour.
Thank you so much, Rahil, for such a wonderful presentation, but also for the work that you've done. The way that this has really moved and the way that you've moved the needle has been incredibly impressive and had major impact. So thank you. So I wanted to remind everybody, please, to fill out the evaluation survey. We very much value your feedback. And if you have questions, chat them into the chat box, and we will try and get to all the questions raised. So the first question is, how does the HealthySteps person coordinate with other people in the pediatric practice, and how do you differentiate roles with mental health workers, including social workers, child life, infant mental health consultants, health psychologists, etc.?
Great question. Usually, even where there's been integrated behavioral health already in a pediatric practice, there hasn't been a real focus on infants and toddlers. Not always, but usually. So if you go to most pediatric practices that have some sort of team-based care already, and they might have a social worker for the whole pediatric practice, they might have a child psychiatrist who comes in a day a week or something. Usually that's not focused on infants and toddlers. When a social worker has been doing maybe concrete services and resources and referrals for families with infants and toddlers, that's great. That means that that social worker is going to be part of the Healthy Steps team. It's not, the Healthy Steps specialist doesn't have to do all 8 of those core components. The practice needs to do all 8 of those core components. And we really hope that this is true practice transformation. So fantastic if you've already got a community health worker working on care coordination and systems navigation. And maybe you've had a social worker who's already been doing those short-term behavior and development consults, right? And so you all do this together. We see lots of huddles, right, in the beginning of each session, so we make sure everyone knows who's coming in and who's sort of playing point on that. And the basic reality of it is you need that team-based care because you could have 3 Healthy Steps Tier 3 families all show up for 10 o'clock well-child visits with 3 different pediatricians. And you've got to figure out how to manage that, and so you need that team. Every site, as part of their onboarding, has to create an implementation plan that very clearly delineates these workflows that the question was asked about. Who's doing what goes to whom. And I got to tell you, even at Montefiore, in our biggest practices, we had a child psychiatrist, a school-age and adolescent psychologist, a Healthy Steps specialist, a community health worker, and a general practice social worker, and there was more than enough for everybody to do when you really start asking the questions and trying to be helpful.
Thank you very much. Okay, so one other question is, how is the Healthy Steps position funded at the various practices?
Great question. For those of you who know anything about Medicaid, you'll maybe appreciate my favorite thing about Medicaid. Someone leaned in close to me pre-COVID and was like, Rahil, you want to know the problem with Medicaid? I was like, yes. He said, it's not Medicare. And so the great joy of having programming in 23 states, Washington, D.C., and Puerto Rico is also the great challenge that you have, 25 different approaches to Medicaid benefits. And we primarily focus on children and families with Medicaid or children's health insurance and otherwise low income. I'd say there's 3 buckets, basically, of how the Healthy Steps specialist is funded. Almost always, initially, it's philanthropically, quite honestly. So someone gets a grant, not always just a small local grant, sometimes a big federal grant. There are project launch dollars, for example, that fund Healthy Steps specialists in New York and other states. There are federal CMS grants through INC, the Integrated Care for Kids dollars that fund Healthy Steps specialists. And sometimes there's a small family foundation in your community that funds your Healthy Steps specialist. The goal always is to get away from that less reliable philanthropic funding and get toward more public funding, which means Medicaid reimbursement and health system reinvestment. So I'll take the easy one first. Health system reinvestment means that the health system says, wow, we're seeing that ROI. We're seeing that to 104% ROI. We're seeing decreased emergency room visits, better linkage with our dentist, and we're just going to pay for this because it is very affordable. I've been told not to say cheap, so affordable, right? We're going to reinvest the savings also that we're seeing because of the 2-generation dyadic work. We have a payer, for example, in Washington, D.C., that saw that those mothers of the Tier 3 Healthy Steps children were some of their most active utilizers of the emergency room. Bring in Healthy Steps and mom's use of the healthcare system changes. Well, that saves serious dollars, right? And so we invest those dollars and just pay for prevention. On the Medicaid side, it varies from state to state because the problem with Medicaid, not Medicare. So in some states, there are enough codes, fee-for-service codes open, that align with HealthySteps services, that you can get enough reimbursement to pay for that HealthySteps specialist salary. Just like pediatricians. Nobody asks how pediatricians are funded, right? They bill for services, you make money, and you pay their salary. So, for example, that's happening right now with a pilot in Ohio. In New York, we have seen that if you have a licensed psychologist billing all available open codes right now, you're probably going to get about $45,000 of reimbursement every year. That's not including all the screening reimbursement on top of that, because usually that goes with pediatrician's visit. We are working with some payers around some value-based payment solutions. The one I'm most excited about is really looking dyadically at these, 2-gen parents and children enrolled in the same health plan. And we are also, in California, about to really have our sites utilize what I've been yammering on about for years, but I finally have such a wonderful national office team on policy and finance led by Jennifer Tracy, who is a wizard on all these things, remember how I talked early on about that well child visit and how you don't need a pediatrician, you don't need a diagnosis and pediatricians get paid for that? We need the exact same thing, parity, on the mental health and development side. We need a set of well child mental health and development visit codes that align with the pediatric well child visits, but are focused on the things that we're focused about, and pay them just like you pay for the well child visits. So we have a health plan in California who is about to turn that on. So those are just some examples, but it's a great question. Oh, Evelyn, you're muted.
Sorry about that. People wanted to know how they could find out where HealthySteps clinics are located. Somebody wants to bring this to Connecticut and wanted to know if there were any plans. So people are really sold on trying to figure out how to expand and grow. So maybe you can let us know where to find resources, and also if people have an interest, where to advocate. Absolutely. So HealthySteps.org is our website. Scroll all the way down to the bottom and you'll see our site. Little secret to whoever wants to bring it to Connecticut, I'm in Connecticut right now, and we have a site in Hartford. We just have one site so far in Connecticut. They came on board about a year ago in the Wheeler Clinic. If you know Connecticut, you know the Wheeler clinics that are actually mental health clinics. So they've done what I like to call reverse integration, that they've brought pediatrics into the mental health system and brought HealthySteps alongside. Connecticut's doing some wonderful work around early learning and the Bridgeport work and so on and so forth. So just go to HealthySteps.org, and then there's Become a Site up in the upper right-hand corner also. Click on that, and it'll ask you for a little bit of information. And if you don't know all the answers, just, you don't know all the answers, that's fine. And that'll get you into our system and get you connected for a one-on-one conversation with me or one of my colleagues to really help you think through about how to do this. Terrific. So somebody wanted to know how you train your staff to be culturally attuned and sensitive. Great question. So just to clarify, at the national office, we have a team, and then the HealthySteps specialists are all employed by the practices, right? So we don't hire them, but we do give them lots of training. But I do think about it differently. I think about my responsibility at the national office as the leader of this national office to really accurately and appropriately address issues of diversity, equity, and inclusion within our own staffing, hiring, staff support, to make sure that the program that we're creating has a strong family and parent voice. I'm so excited next year in 2021 that we're going to be co-creating alongside parents our Parent Ambassador program, so that parents really give us feedback first on the creation of the Parent Ambassador program, because that makes sense, but then very importantly on the programming that comes out of the national office. For the HealthySteps specialists, we do every year, there's a pediatric pre-conference in front of the annual 0 to 3 conference. It's a full day-long approach that we meet with all the HealthySteps
members at the conference, and the last 2 years have been focused on issues of culture. When you talk parenting, I can't think of anything much more culturally bound than parenting, right? Our ideas about what kids should eat and how they should eat and who should feed them. Our ideas about where they should sleep and who should sleep with them and when they should sleep. Our ideas about what's effective discipline versus what crosses the line. All of those things can be so culturally bound. And if you are not culturally respectful, responsive, we know, I don't really think about it as cultural competence anymore, you know, like work in Queens and you've got 62 languages spoken every day, as you well know, right? So like, you're not going to be expert in 62 different cultures, but to be culturally humble, to have that cultural humility, to understand your own stuff, where you come from and your own history and your own parenting, has been the way that we've approached it through so much of the training. All of the resources that we create at the national office are in Spanish and English, and we spent the last year and a half rewriting every single resource we have to make sure it's at a 4th grade reading level instead of where we were before, which was more at 6th or 7th. We have some sites that then we allow to then translate into Somali or the language that's really that they're serving. It's a lifelong journey. Our national office retreat is next week, and we're spending the whole time focused on issues of anti-bias, anti-racist, working under the leadership of a consultant we've hired, who some of you may know because she's done a webinar for this group before, Dr. Dana Crawford. So she's going to come in. We've hired her to do our national office retreat on all things. So we're on it, but can always learn and always get better about it.
So if people wanted to know if they were looking for other resources, where they could go, and I'm presuming that you have a HealthySteps website that we might be able to direct people to?
Yep, HealthySteps.org has a bunch of stuff. You will see, though, like I said before, we're redoing it, so it's not perfect. So feel free to reach out if you have questions. And if you see things that you wish were on the website that weren't, it might mean that we just don't have it organized correctly and you can't find it. And it might mean that it's behind our password-protected portal. So once you become a site, there's a whole nother, basically, website that you get access to that has a bunch of things that you wouldn't be able to see if you're not a site. So feel free to reach out. My email is rbriggs@0to3.org. I'll put it in the chat before we're done so folks can have it. The good thing about having a funny name like Rahil Briggs is I'm pretty easy to Google as well, and I'm abnormally responsive to email. So happy to follow up with people if you don't see something that you want to see. Like I said, it either means we don't have it, you can't find it, or it's behind that password-protected portal. So
terrific. Somebody mentioned the difficulty in certain lower socioeconomic areas in terms of accessing early intervention services and the dearth of providers. So I didn't know whether you had any suggestions or thoughts about kind of how to really facilitate that.
I was distracted because I was typing into the chat, but I think I heard you, Evelyn, correctly, that it's about rural areas and access.
Just getting access to early intervention, and I don't know that you have the answer to that, but the fact that, you know, one of the outcomes of HealthySteps is identifying children in need of other kinds of resources, and whether or not you have any strategies for dealing with the shortages.
Yes. Early intervention, if you look nationally at who gets early intervention services, and you look at it through a race and ethnicity lens, they're more likely to be white. And if you look at it through a socioeconomic status lens, they're more likely to be white and middle class than the population that needs the services or would qualify for services. So that tells me that we've got a problem, that we've designed a system that doesn't work for everybody who needs and wants access to that system. the Healthy Steps specialist spends a significant amount of time making sure that services happen. So in that same USA Today article that I was referencing that came out yesterday, they talk about the community health worker who's part of the Healthy Steps team at Montefiore going to the Department of Education with the family. This was about CPSE, not EI, right? It was about preschool services. But going and being there in that meeting about the IEP, the Individualized Education Plan, and making sure the kid got what they needed. Unfortunately, we have created a system, like I said, that doesn't work for everyone who needs it and requires effective advocacy to navigate through it. Yes, there have been cuts in early intervention, but there are still services, and it takes, unfortunately, pretty effective advocacy sometimes to make sure that families get those services.
Great. And how are you handling care coordination during COVID-19?
It's been a challenge. So we started doing, right when COVID started, we started weekly town halls with all of our sites around the country. They were amazing. We'd get 75 to 100 people on some of those early town halls, and they were from all over the country, and some of them were drowning, and some of them were just starting to see COVID, and the ways in which they sort of helped each other think through some of these challenges was really inspiring to see. As things closed around people, you know, as the community-based organizations closed and the childcare closed and so on, what we mostly saw was that people just kept on reinventing themselves and going above and beyond. So we saw people do what they called infant survival kits, where any baby that was born and came into the pediatric practice got this huge kit with thermometers and diapers and, you know, formula and books and the like. We started a national partnership with Baby to Baby, which is a national network that partners with diaper banks and or helps you turn yourself into a diaper bank. And so we're piloting that in our South Florida sites, but hope to really take that national across the network. Food became absolutely critical, and so really making sure you knew which was that food bank that was open and how to help, you know, how to supplement transportation to help families get there. It's an extraordinary network of providers that really say we're going to do whatever it takes to make sure that infants and toddlers get what they need, because even in the best of times, pre-COVID, it was a hard system to navigate.
Someone wanted to know also, in terms of handling conflicts between disciplines, is there a Healthy Steps approach? How do you handle different disciplines in the pediatric practice and kind of conflicting or differing views?
Great question. Really good question. So I think the discipline, the conflict that happens usually in the beginning is that people worry a couple things. People worry that Healthy Steps is going to come in and do all the fun parts of the work. Like the Healthy Steps specialist is going to get to have the long conversations with family and talk about feeding, and they just have to give the vaccination. People worry, you know, there's a reality that people have to keep their numbers up and have enough billables and what have you. And so if there's other behavioral health providers or social workers or other folks in the practice pre-existing, there can be a sort of like, whoa, who are you? And are you going to start taking my patients? Like I said, that happens usually in the beginning. And then when we get in there and develop these workflows, there's more than enough work for everybody. Once you start asking these questions, once you start universally screening for social determinants of health every single year, you uncover a lot of work for everybody to do, right? Once you start universally screening effectively for maternal depression, you got a lot of work. You know, it takes a whole day to go to the Department of Education and get this IEP solved for a kid, right? There's enough for everybody to do. And I say this with nothing but respect, love, and admiration for all my pediatrician colleagues. There is a medical hierarchy. It's alive and well, right? And so we really talk with Healthy Steps specialists about the idea that we are guests in the medical home, that you've heard me use the phrase that we borrow in the trust instilled in the pediatrician to effectively reach families. We are conscious of that. We try to instill that in our folks and help them really see it that way. And it also really matters who you hire. I've made a lot of mistakes, well, a handful of mistakes, hiring Healthy Steps specialists back when I was at Montefiore, because I neglected to pay attention to how important flexibility is. I could teach you Spanish, but I cannot teach you how to be flexible. You are either flexible or you are not, right? And the need to be flexible, to understand these hierarchies, to work with all these different disciplines, and to not need that 50-minute therapy visit with 10 minutes for note writing and a front desk who doesn't let anyone pass without the buzzer, and it's quiet and you've got a noisemaker outside the door. Like, that is not pediatric primary care. Pediatric primary care is busy and it's loud. You could have 3 pediatricians knocking on your door all at the same time, and they each have an issue, and you've got a mom in your office crying, but it's not like a normal mental health clinic. And so for some people, that sounds miserable. And I made a mistake and hired them. And for other people, it sounds really exciting and really invigorating and interdisciplinary, and every day is different. And I'd love to work there, but you've got to make sure you get that right, or else you're going to have real challenges.
You've triggered a lot of interest in terms of people wanting to expand and really reach out around Healthy Steps. Someone asked the question, if someone's trained as a Healthy Steps specialist, do they have to find their own clinic, or are there ways that there could be linkages that are established for people who are interested in doing this work?
Our Healthy Steps specialists never suffer for jobs, especially in New York where there's 47 practices. Everyone's, there's a little bit of poaching that goes on. Poaching is the negative side of it. The positive side of it, like, they leave one place and they go start it up somewhere else. There's lots of movement. So if anyone is, trained up in a Healthy Steps practice, easy to get a job. We have a monthly newsletter that actually just went out this morning, I saw, where we list job openings for our network, and so that gets spread around. I'm very active on LinkedIn and try to present that and so on and so forth. So no shortage. If anything, no shortage of jobs. If anything, something I think about is a shortage of people trained as Healthy Steps specialists, right? And how we need to do better about partnering with higher education and getting some of this just in the sauce of places.
Terrific. So the last question is, how many Healthy Steps specialists are there per each site, or how do you determine the metrics?
Great question. So nationally, there are a little bit over 200 Healthy Steps specialists, and so it's a little bit over 1 per site. But if you remember that that return on investment slide I showed, it said 1 Healthy Steps specialist per about 2,000 kids birth to 3 in a site. So if you have 4,000 kids birth to 3 in a site, you might need more than 1 Healthy Steps specialist. If you only have 1,000 kids birth to 3 in a site, you might split 1 Healthy Steps specialist between 2 practices. Use telehealth, use different scheduling. So we have about a fifth to a quarter of our sites are actually in very rural areas across the country, in Arizona and upstate New York and other places. And so they're using some of the, even pre-COVID, some telehealth, or some, like, maybe well child visits for young children only happen on Monday, Wednesday, Friday in this clinic, and on Tuesday, Thursday this clinic, right? But the basic staffing is 1 per 2,000 kids birth to 3.
Impressive. Well, thank you so much. And I wanted to remind everybody, please do fill out the evaluation in the chat box. You will be getting a follow-up if you're looking for CEUs for this training. And also, we will be posting both the recording of this as well as the PowerPoint on the TTAC NY website. So thank you so much, Rahil. This has been so incredibly informative. Thank you.
Thank you, Evelyn. Thank you for everything that you have done for New York's children for so long. When I said that quote about Jack Shonkoff, and early childhood, brain development, middle age 3. I remember probably over 10 or 15 years ago being on a panel with you and Jack Shonkoff and knowing that you were going to be a critical link to helping move policy and programming for New York's children. So thank you for everything that you have done and this whole group with McSilver and TTAC, and thank you for inviting me.
Thank you so much. Be well, everybody. Take care. Bye-bye.
Bye.